Welcome back to the deep dive. We are jumping right back into the curriculum for integrated neurobiology, structure, function, and pathology.
It's good to be back.
If you've been with us for the previous sessions, you know the drill. This is a 42 lecture course. It's designed specifically for the physician scientist.
Right. We're always trying to find that intersection, the clinical practice on one hand and the deep biological mechanisms on the other.
Exactly. And we are, I think, firmly in Module 2 now.
We are. Module 2, Neuroanatomy Overview and the Physical Environment. We spent the last few sessions laying the groundwork, the gross anatomy from Blumenfeld. We've basically built the map.
And now we have to learn how to actually read it or navigate it.
That's the perfect metaphor. And that brings us right to today's topic.
It does. We are covering Lecture 5, the neurologic examination as a localization tool. And I have to say, just looking over the syllabus and the source material from Blumenfeld chapters 1 and 3, this feels like a real pivot point for us.
It is the absolute pivot point. It's the moment we move from pure structure to functional application.
Yeah.
Because you can memorize every single nucleus in the brainstem.
Which we've tried to do.
Right. But if you can't elicit the signs that tell you which nucleus is failing, then that knowledge is, well, it's purely academic. This lecture is all about the logic.
The logic of localization.
The logic of localization. It's about answering the first question, always the first question. Where's the lesion? You can't even start thinking about what is the lesion until you know where you're looking.
I think there's a tendency, especially now with all the modern tech, to see the physical exam as a formality, maybe.
Oh, absolutely.
You tap the knee, shine a light in the eyes, and then you rush the patient to the MRI suite to see what's actually going on.
And this lecture, the whole philosophy behind it, argues that that's completely backward. The exam is the primary data gathering tool, not the scan.
The scan confirms, the exam discovers. That's
the central thesis we really need to internalize today. You said it perfectly. Imaging is structural, the exam is functional. So we're going to walk through the 15-slide deck from the course material, and we're going to just dismantle that idea that the exam is a ritual.
It's a hypothesis-generating engine.
Exactly. So let's get straight into it.
Okay, pulling up slide 1, title and learning objectives. Visually, what we have here is this really high-res image of the arrowhead of neurologic differential diagnosis. It looks complex.
It does. We'll break it down later, I promise.
Yeah.
But notice what it's sitting next to.
The classic tools of the trade, the reflex hammer and the tuning fork.
The juxtaposition is intentional. The hammer and the fork, they're the input. That's your data gathering. The arrowhead, that's the synthesis. That's the diagnosis.
And the learning objectives here are pretty ambitious for one session.
They are. First, we have to map the 6 components of the neuro exam to specific anatomical systems. It's not enough to know how to test something. You have to know where in the brain or spine you are testing.
The second objective listed is differentiating upper motor neuron, or UMN, versus lower motor neuron, LMN, lesions.
Which is, I would argue, the single highest yield binary decision in all of clinical neurology. If you get that wrong.
Everything else goes wrong.
Everything. You'll order the wrong tests. You'll chase the wrong diseases. A spinal cord problem versus a peripheral nerve problem. It's a fundamental fork in the road.
And the final objective is to apply that arrowhead model and something called the vindicate model. So the mission is clear. We're moving from the what of anatomy to the how of diagnosis.
And we're doing it at that physician-scientist level. We're not just learning a checklist. The goal here is to understand the mechanism behind the reflex, the physics behind the gait, the geometry of the brainstem.
Okay, let's move on. Slide 2. The logic of localization. There's a flowchart here that really hammers home your point about the detective work. It breaks it down into 2 steps. Step 1, anatomic diagnosis, where? Step 2, etiologic diagnosis, what?
Right. And this slide, it's designed to address the elephant in the room.
Which is,
why do we still do this? Why not just scan everybody from head to toe? And look at the flowchart. The anatomic diagnosis, it says it comes from 2 places only, the history and the examination. The MRI isn't even in step 1.
Because if you don't know where to look, the scan is basically useless.
Or worse than useless. It can be actively misleading.
Yeah.
I mean, think about a patient who comes in with dizziness, a very common complaint.
Sure.
You scan their brain, you might see a little tiny incidental white matter spot that's been there for 20 years. And you might be tempted to blame the dizziness on that.
And you'd miss the real problem.
You'd miss the fact that the patient actually has a peripheral vestibular issue, something in the inner ear, which, by the way, a brain MRI can't even see. The exam tells you where the lesion is. It gives you the coordinates.
The slide also makes this distinction between focal and diffuse. This feels like the very first fork in that road.
It is. A focal lesion is, think of it like a sniper shot, a tumor, a stroke, a traumatic injury. It affects a very specific set of coordinates in the nervous system. A diffuse lesion, on the other hand, is a system-wide failure. It's something like metabolic acidosis or meningitis or a drug intoxication. The whole system is sick.
And the physical exam can sort that out quickly.
In about 90 seconds. I mean, if a patient is confused but they're moving both arms equally well and their reflexes are symmetric, you're immediately thinking disuse. But if they're confused and their right arm is paralyzed...
You're thinking focal, a sniper shot to the left side of the brain?
Exactly. The slide also mentions supratentorial versus infratentorial.
Right, this refers to the tentorium cerebelli. That's the membrane separating the cerebrum from the cerebellum and brainstem.
It's like dividing the head into upstairs, the cortex, the hemispheres, and downstairs, the brainstem and cerebellum. And that distinction is vital.
Why so vital?
Because the downstairs is very tight real estate. It's a very crowded neighborhood. A small lesion there can cause catastrophic damage and threaten life very quickly. The upstairs, the cortex, has a bit more redundancy, a bit more room to swell.
Got it. Moving on to slide 3, structure of the examination. There's a nice graphical hierarchy here showing what it calls the big 6 subdivisions of the exam.
This is really the syllabus for the exam itself. And it's ordered, for the most part, cranial to caudal, from head to toe.
So we have mental status, cranial nerves, motor, reflexes, coordination and gait, and finally, sensory.
And the slide explicitly maps these to anatomy, which is the whole point. Mental status. That's a test of the global brain, the association cortex.
What does that mean, global brain?
It means when you test mental status, you're testing the integration of the whole system. You're asking 2 questions. First, is the battery charged? That's the reticular activating system. Is the patient even awake?
And second?
Is the software running? That's the cortex. Is
Right.
the patient making sense?
Okay. Then cranial nerves maps to the brainstem, motor, reflexes, and sensory. Those are all the spinal cord and the long tracts.
Right. And coordination, that's the cerebellum's job. It helps to think of this as checking different rooms in a house. You don't just walk in the front door and glance around. You have to check the plumbing, the electrical wiring, the foundation. The big 6 just ensures you don't skip a room.
The slide also has a reference here to neuroexam.com.
Yes, and that's an essential resource mentioned in the syllabus. You can read about something like clasp knife spasticity in a book, but it's another thing entirely to see it in a video. You have to visualize these deficits to be able to recognize them at the bedside.
All right, let's dive into that first pillar then. Slide 4. Mental status is phrase change. The hierarchy of consciousness. The visual here is a diagram of the brain, and it's highlighting the reticular activating system and the association cortices. This is where we figure out if the patient is even there.
This is the foundation. It's step 0. You cannot ask a comatose patient to interpret a proverb. So the slide breaks this down into 2 key parts, the level of alertness and the content of consciousness.
And the level of alertness depends on that reticular activating system, the RAS.
Correct. The RAS is a collection of nuclei deep in the brainstem. Think of it as the basement. And its one and only job is to keep the lights on in the cortex, the penthouse.
So if the RAS is damaged,
Or if the connection between the basement and the penthouse is severed, the patient is comatose, the lights are out. And the slide emphasizes documenting this precisely. Don't use vague words like lethargic.
be objective.
Be objective. Say opens eyes to voice or withdraws to a painful stimulus. That's data.
Okay, so once we establish that they're awake, we look at the content. This is orientation, memory, language. The slide makes a distinction here that I think trips a lot of people up. Language versus speech.
This is a classic physician-scientist distinction. It's critical. Speech is a motor act. It's purely mechanical.
Muscles.
It involves the muscles of your tongue, your lips, your pharynx, and your diaphragm pushing air. If that machinery is broken, say from a cranial nerve lesion, you get what's called dysarthria. The words are slurred and indistinct, but the grammar, the word choice, it's all intact.
Whereas language is cognitive, it's software.
Language is the manipulation of symbols. It lives in the dominant hemisphere of the brain, usually the left frontal and temporal lobes. If that area is damaged, you get aphasia. The patient might have perfect muscle control, but they can't find the right word. Or they might speak in a fluent but meaningless word salad.
So you can be aphasic without being dysarthric.
And vice versa. They're completely separate systems.
The slide also breaks down how we test by lobe. Frontal lobe for sequencing and logic. But I wanted to ask about the parietal lobe because it lists dominant versus non-dominant functions.
Right. The parietal lobes are like the brain's high-level association maps. The dominant parietal lobe, which is usually the left, handles symbols. Things like calculations, distinguishing right from left, writing.
And a lesion there causes Gerstmann syndrome.
Exactly, which is a constellation of deficits. Difficulty with calculation, difficulty with writing, and this very specific left-right confusion.
And what about the non-dominant parietal lobe?
That lobe handles our spatial attention. It builds our internal map of the world, of space. And a lesion there, usually on the right side, can cause a profound syndrome called neglect.
Neglect.
The patient literally stops processing the left side of the universe. They might shave only the right side of their face, or if you ask them to draw a clock, they'll cram all the numbers onto the right side.
It's not that they can't see the left side.
It's that for their brain, the left side has ceased to exist in their internal model of reality.
That is just profound. It
Yeah.
shows that seeing isn't just about your eyes, it's about the brain constructing a space for things to exist in the first place.
Exactly right. And that's what a good mental status exam can reveal. It reveals the integrity or lack thereof of that internal construction.
All right, let's move down the anatomy. Slide 5. Cranial nerves, the brainstem barometer. And the visual is a nice schematic of the brainstem. Midbrain, pons, and medulla.
The brainstem is extremely high-value real estate. It is the bottleneck for every single signal going up to the brain and every single command coming down to the body.
It's the information superhighway.
It is. And because the cranial nerve nuclei are scattered all along its length, they act as perfect little mile markers for us.
And the slide groups them. So the midbrain has cranial nerves the 3rd and 4, the pons has V through 8, and the medulla has 9X through 12.
This is the 4-4-4 rule, roughly speaking. It's a great way to remember it. So if the pupil or eye movements are abnormal, that's CNEAGN in 5,
Yeah.
you should be looking at the midbrain, the attic of the brainstem.
Okay.
If the sensation or movement of the face is affected, CNV, the ACEF, you're looking at the pons, the middle floor.
Oh.
And if the tongue or the palate or the voice is affected, 9XX-HEE, you look to the medulla, the basement.
And this is where we really get into the geometry of localization. The slide mentions crossed signs. It calls this the hallmark of a brainstem lesion.
This is one of those concepts that you have to visualize the wiring diagram.
Yeah.
So imagine 2 elevator shafts running down through the brainstem. One shaft is the corticospinal tract. That's the main motor line to the body. It runs all the way down, and it only crosses over, it decussates at the very bottom where the medulla meets the spinal cord.
So while it's in the brainstem, the motor tract for the left side of the body is actually still on the right side of the brainstem.
Exactly. It is not crossed yet. Now think about the second shaft, the cranial nerves. They exit the brainstem and go directly to the structures of the face on the same side. They do not cross.
Okay, I think I see where this is going. So let's simulate a stroke in the right pons.
Okay.
What happens?
Great. So a small lesion in the right pons. First, it's going to hit the right facial nerve nucleus. The result, the right side of the patient's face is weak. Ipsilateral, same side.
Right.
But that exact same lesion also hits the corticospinal tract that's just traveling through the right pons. And remember, that tract is destined for the left side of the body, and it hasn't crossed yet. So what do you get?
You get left arm and leg weakness,
Right face, left body.
the crossed sign.
That is the crossed sign. And whenever you see the face weak on one side and the body weak on the opposite side, you know, the geometric certainty that the lesion has to be in the brainstem.
As opposed to a stroke up in the cortex.
Exactly. A big stroke in the right cortex, for example, would cause left face weakness and left body weakness. Everything is on the same opposite side.
So matching sides means cortex. Alternating sides means brainstem.
It's a beautiful, elegant geometric certainty, and that is the power of the cranial nerve exam. It lets you pinpoint the vertical level, midbrain, pons, or medulla, and the horizontal location of the lesion.
Okay, let's descend further. Slide 6. The motor exam pathway analysis. We've got a diagram here comparing the corticospinal tract, the UMN, and the anterior horn cell, the LMN. This is the slide you called high yield.
This is the concept. If you understand this, you are miles ahead. This is what separates the neurologist from the casual observer. We have to be able to distinguish between an upper motor neuron lesion and a lower motor neuron lesion.
Okay, let's start with the definitions. What are they?
The upper motor neuron is the executive. It lives up in the cortex. Its axon travels down the spinal cord to issue commands. But, and this is key, it never touches a muscle directly.
And the lower motor neuron?
The lower motor neuron is the manager. It lives in the spinal cord. It takes the order from the executive. Its axon exits the spine, and it plugs directly into the muscle. It's the final common pathway.
So if we have a lesion in the lower motor neuron, we kill the manager. What happens to the muscle?
The muscle is completely cut off from the grid. It gets no signal to move, so it becomes weak and flaccid. But crucially, it also loses all the trophic factors, the chemical nutrients that the nerve normally provides, so the muscle withers away. You see severe atrophy.
And the slide mentions fasciculations.
Right. As the individual muscle fibers are dying and becoming hypersensitive, they start to twitch spontaneously. Those little twitches under the skin are fasciculations. So for LMN, think flaccid, atrophic fasciculations.
Got it. Now, the UMN lesion, the executive is dead, but the manager and the muscle are still connected. What happens there?
This is the fascinating part. The executive's job isn't just to say go. A huge part of its job is to say stop. The cortex sends constant inhibitory signals down to the spinal cord to dampen the reflexes. It keeps the spinal cord calm and in check.
So if you cut that wire, if the executive dies,
All that inhibition is lost. The spinal cord becomes hyperactive. It's what we call a release phenomenon. The weakness is still there, of course, because the go signal is weak or gone. But the tone in the muscle increases.
it becomes tight. Spasticity.
Spasticity. And the reflexes become exaggerated, hyperreflexia. It's a completely different clinical picture.
The slide also mentions pronator drift. Why is that so important?
Pronator drift is probably the most sensitive clinical sign we have for a subtle UMN weakness. You ask the patient to hold their arms straight out, palms up, and close their eyes. For complex anatomical reasons, the supinator muscles that keep the palms up are weaker than the pronator muscles when the UMN system is stressed.
So what do you see?
If there's a subtle lesion, that arm will slowly drift downwards and the palm will turn over. It'll pronate. It can pick up a weakness that a simple hand squeeze test would completely miss.
Okay, moving to slide 7. Reflexes the spinal loop. This connects directly to what you were just saying about inhibition. The visual shows that classic reflex arc. Sensory afferent in, synapse in the cord, motor efferent out.
The deep tendon reflex is a local loop. It doesn't actually require the brain to happen. You tap the tendon, that stretches the muscle, the sensory nerve fires. Its synapses directly on the motor nerve in the spinal cord, and that motor nerve fires back to contract the muscle. It's a basic safety mechanism to maintain posture.
But the brain is always modifying it.
Correct. The UMN from the cortex is constantly dampening it. So we grade reflexes on a scale, usually from 0 to 4+.
And 2+ is normal.
2+ is normal. 0 is absent. That means the loop itself is broken somewhere. That's an LMN lesion. And 4+ is clonus.
Can you describe clonus?
Clonus is what happens when the loss of inhibition is so severe that the reflex loop gets stuck in a feedback cycle. So you push back gently on the patient's foot, stretching the calf muscle. In a normal person, the foot might push back once.
And with a UMN lesion.
With a severe UMN lesion, the foot just beats rhythmically against your hand. Tap, 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 tap. It's the spinal cord firing uncontrollably without the cortex there to tell it to please stop.
Wow. And we have to talk about the Babinski sign, the plantar response.
The most famous sign in all of neurology. You take a key or a stick and you scrape the bottom of the foot from the heel up to the toes.
In a healthy adult, the toes curl down.
They curl down. This is the normal cortically controlled response. But in a patient with a UMN lesion, when that executive is gone, a primitive reflex returns. The big toe goes up and the other toes fan out.
So a positive Babinski isn't a new abnormal thing appearing. It's an old primitive thing coming back.
That is the perfect way to understand it. It's an infantile reflex that unmasks itself when the mature corticospinal tract is damaged. It is a definitive, hard sign of central nervous system pathology.
All right, slide 8. Coordination and gait. We're looking at a picture of the cerebellar homunculus.
Right, so if the motor system is the engine, the cerebellum is the quality control center.
Yeah.
It doesn't start the movement, it corrects it on the fly. It's constantly comparing what you intended to do with what your body is actually doing, and it fixes the error in real time.
And we test this with appendicular tests like finger to nose and truncal tests like gait.
Exactly. And there's a localization map here too. The cerebellar hemispheres, the sides of the cerebellum, they control the limbs on the same side of the body.
Ipsilateral.
Dipsilateral. So if you have a tremor in your hand when you're reaching for a cup, an intention tremor, or you keep overshooting the target, that's dysmetria. That's a hemisphere problem.
And the trunk.
The vermis, the midline strip of the cerebellum, controls the trunk. So you might have a patient with perfectly steady hands, but when they try to stand or walk, they look like they're drunk. a wide-based ataxic gait.
The slide calls gait the ultimate integrator.
And it really is. I mean, just think about the physics of walking. You need motor strength to push off. You need sensation from your feet to know where the ground is. You need the cerebellum for balance. You need vision to navigate obstacles. If any one of those systems fails, the gait fails.
Which is why we do the tandem gait test.
That's why we make the patient walk heel to toe. It removes the wide base of support, and it forces the system to be perfect. If there is a subtle deficit anywhere in that network, tandem gait will expose it.
Moving to slide 9, the sensory exam. The visual here is a cross-section of the spinal cord, showing the posterior columns versus the anterolateral systems. Sensory exams always seem tough because they're subjective.
They are subjective. You're relying on the patient's report. But anatomy saves us again. Because you have two main sensory highways running up the spinal cord, and they are anatomically distinct.
Okay, what are they?
Highway 1 is the posterior columns. These run up the back of the spinal cord. They carry vibration sense, proprioception, which is your joint position sense, and fine touch.
In highway 2.
That's the spinothalamic tract. This runs up the front side of the cord. It carries pain, which we test with a pinprick, and temperature.
And the crucial difference, I'm guessing, is where they cross over to the other side of the body.
This is the whole key. This is the Brown-Séquard mechanism mentioned in the discussion. The spinothalamic tract, the pain and temperature pathway, it crosses over immediately upon entering the spinal cord at that level.
And the posterior columns?
They do not cross.
Yeah.
They travel all the way up the same side and don't cross until they get to the brainstem.
Okay, so let's do a thought experiment. You have a lesion that cuts the right half of the spinal cord at, say, the waist level.
Okay, a right hemisection of the cord. What do you lose? Well, you lose vibration and position sense on the right leg because those fibers were traveling up the right side and got cut.
Makes sense.
But you lose pain and temperature sense on the left leg because those fibers came in on the left, cross over immediately, and were traveling up the right side of the cord when you cut it.
That's a dissociated sensory loss. One modality is gone on one side, the other modality is gone on the other. That specific pattern tells you exactly where the spinal cord lesion must be.
It's another geometric certainty. And the slide also clears up a really common misconception here about the Romberg test. The Romberg is not a cerebellar test.
Explain that, because I think a lot of people think it is.
They do. The Romberg test is a specific test of proprioception and tests the posterior columns. So, look, you need 3 things to stay upright.
Yeah.
Your vision, your vestibular sense from your inner ear, and your proprioception from your feet. You can stand with any 2 out of 3. In the Romberg test, you ask the patient to stand with their feet together and then close their eyes. You've just removed vision from the equation. Now they're relying only on their inner ear and their proprioception if they immediately start to fall.
It means their proprioception was already gone, and they were using their eyes as a crutch the whole time.
Precisely. It localizes to the posterior columns, not the cerebellum.
Okay, slide 10. Special situations, coma, and brain deaf. This feels like a shift in gears. How do you examine someone who can't follow any commands?
You drop back to the primitives. If the cortex is offline, if the patient is in a coma, we can still test the brainstem reflexes to see if the core machinery is intact.
So what are you checking?
We check the pupillary light reflex, that tests the midbrain. We check the corneal reflex, where you touch the cornea with a wisp of cotton, that tests the pons. And we check the oculocephalic reflex, the doll's eyes maneuver.
The visual shows a head being turned and the eyes moving in the opposite direction.
Right. In a comatose patient who has an intact brainstem, if you turn their head quickly to the left, their eyes should move to the right. They try to stay fixed on the horizon because of the vestibular system's connection to the eye muscles. It looks like a doll's weighted eyes.
And if they don't?
If the eyes stay stuck in the middle of the head and turn with the head, it means that brainstem reflex is gone. That is a very bad sign.
The slide also touches on the concept of brain death.
Brain death is a very specific legal and medical definition. It means the irreversible loss of all brain function, and that includes the brainstem. We have to prove there are absolutely no reflexes and, importantly, no drive to breathe.
The apnea test.
That's the apnea test. We allow carbon dioxide to build up in the blood. CO2 is the body's strongest possible drive to breathe. If the CO2 level shoots way up and the brainstem still doesn't trigger a single breath, it means the respiratory center in the medulla is dead.
Moving on to slide 11, the general physical exam as a neuro tool. The visual here is a montage of non-neuro signs. A stiff neck, an irregular heart rhythm, skin spots.
The brain lives in a body. You absolutely cannot ignore the chassis.
So what are we looking for?
Well, if a patient has a stroke, the first thing you do is check their pulse. Is it irregular? That could be atrial fibrillation and the heart is just throwing clots up to the brain.
Makes sense.
You listen to the neck with your stethoscope. Do you hear a bruit, a sort of whooshing sound? That's turbulent blood flow in a clogged carotid artery. You check the skin. Are there café au lait spots? That's a sign of neurofibromatosis, which might explain the brain tumor you're suspecting.
And the slide mentions Cushing's triad. This sounds like a vital sign pattern that screams emergency.
It is a siren. It's pure physiology. If you have a massive brain bleed, the intracranial pressure, the ICP, spikes. The brain is being crushed. To survive, the brain signals the body to massively increase blood pressure to force blood into the skull.
So you see hypertension.
Severe hypertension.
Yeah.
But the heart reacts to this crazy high pressure by slowing way down bradycardia. And the breathing becomes irregular because of direct pressure on the brainstem.
High blood pressure, low heart rate, and irregular respirations.
If you see that triad, you know the patient is about to herniate. You need a neurosurgeon 5 minutes ago, not a reflex hammer.
Okay, now we get to put it all together. Slide 12, the arrowhead of neurologic differential diagnosis. This is where we move to the what is it phase.
This is Blumenfeld's graphical masterpiece. It's so brilliant. It maps the etiology, the cause against the time course of the illness. The shape of the curve on the graph tells you the pathology.
So let's look at the acute curve.
Events that happen in seconds or minutes, they are almost always structural failures. A vessel bursts, causing a hemorrhage. A vessel clogs, causing an ischemic stroke. Or an electrical storm in the brain, a seizure, bam. It's an instantaneous onset.
Then you have the subacute curve, which is over days to weeks.
That's the realm of expanding masses. An abscess is growing, inflammation is spreading like an MS, or a fast-growing tumor is expanding. The symptoms crescendo over time.
And finally, chronic, which is months to years.
That is cellular failure. It's neurons dying off one by one, Alzheimer's, Parkinson's, ALS, or maybe slow compression from a benign tumor. The slope of the line gives you the category of disease. It's incredibly powerful.
Slide 13 introduces a mnemonic, Vindicate. It looks like a checklist to make sure we don't suffer from premature closure.
That's exactly what it is. It's so easy to get locked into one idea early on. Vindicate forces you to widen the aperture and consider everything.
So what does it stand for?
It's V for vascular, I for infectious or inflammatory, N for neoplastic, D is degenerative or deficiency, like a vitamin deficiency, I is intoxication or idiopathic, C congenital, A autoimmune, T trauma, and E is for endocrine or epileptic.
And the slide suggests using this in tandem with the arrowhead. So if I have a subacute presentation, something that's been getting worse for a few weeks,
then you should prioritize the I's, the N, and the A. Infectious, inflammatory, neoplastic, autoimmune. You wouldn't put vascular at the top of your list for a 3-week decline, and you wouldn't put degenerative at the top for a 3-minute onset. You overlap the time course with the Vindicate list to generate your most likely differential diagnosis.
Okay, let's try to apply this. Slide 14. Case example, localization synthesis. We have a brief case text here. Right face and arm weakness plus non-fluent aphasia, sudden onset.
Okay, let's be the detective. Step 1 is anatomic diagnosis. Where is the lesion?
Right face and arm weakness, and the leg is spared.
Okay, think back to the homunculus map on the cortex. The face and arm are on the side, on the lateral surface.
Yeah.
The leg is on the top in the midline. So this points to the lateral motor cortex.
And it's on the right side of the body, so it has to be the left brain.
Left brain. And the aphasia confirms that location for us.
Right. Non-fluent aphasia points straight to Broca's area, which is in the left frontal lobe, right next to the motor strip for the face.
So our anatomic diagnosis is a lesion in the left posterior frontal lobe. Done. Now, step 2, etiologic diagnosis. What is the lesion?
The history says sudden onset.
Sudden onset. That puts us on the most acute point of the arrowhead. That means vascular or trauma. The case doesn't mention trauma, so we're left with vascular.
So we just need to know the blood supply.
What blood vessel feeds the left posterior frontal lobe? That would be the superior division of the left middle cerebral artery, the MCA. So our final diagnosis is a left MCA superior division stroke.
And we just diagnosed a specific vessel occlusion without ever seeing a CT scan.
That is the whole point. That is the goal. The CT scan is there to confirm that you're right and, critically, to make sure it's not a bleed before you give clot-busting drugs. But the diagnosis was made with history and the exam.
So our final slide, slide 15, conclusion and the screening exam. Because obviously we can't do this full hour-long deep dive on every single patient who comes in with a headache.
Right, practicality matters. So the screening exam is a compressed, high-yield version for low-risk or asymptomatic patients.
What's in it?
You check mental status, you check the key cranial nerve pupils, eye movements, face of case. You do a quick motor check, and conator drift is perfect here. It's so high yield. You check a few key reflexes, and you watch them walk. If all of those things are normal, the probability of a major focal neurologic lesion is very, very low.
The slide uses the term triangulation.
And that's really the summary of this whole lecture. You use the dermatomes, the skin map, and the myotomes, the muscle map, and the reflexes to triangulate the exact location of a lesion.
Can you give an example?
Sure. If the C6 dermatome is numb, that's the thumb, and the biceps muscle, which is C6, is wink, and the biceps reflex, also C6, is absent, you have triangulated a C6 nerve root lesion with a high degree of certainty.
And it mentions EMG and NCS as an extension of the exam.
Right, electromyography and nerve conduction studies. If the physical exam is our clinical look at the wiring, EMG is the electrician's look. It lets us test the circuits directly with electricity and can definitively distinguish between a root problem, a plexus problem, or a peripheral nerve problem.
So the big takeaway is the exam creates the functional map. It tells you where to look.
It creates the hypothesis. And as physician scientists, we don't just order tests blindly, we test specific hypotheses. The exam is how we form them.
That brings us to the end of Lecture 5. It is an incredibly dense topic, but when you break it down into these logic gates, UMN versus LMN, the geometry of the brainstem, the time course, it becomes a really elegant system.
It's biological engineering at its absolute finest, and it sets us up perfectly for our next session.
Which is Lecture 6.
Neuroradiology for the scientist. Now that we know where to look, we're going to learn how to look. We'll get into the physics of CT and MRI, Hounsfield units, T1 versus T2 weighting, and how to actually spot the pathology we just learned how to localize.
I am really looking forward to that. Thanks for listening to this deep dive into the neurologic exam.
See you next time.